Okay. Hi, everyone. My name is Malcolm John again. I'm director of 360 to Positive Care Center at UCSF, which is the general HIV clinic on the UCSF Parnassus Medical Campus. And I want to welcome you guys and ladies to our first abstract-driven session on testing and disclosure. The overriding or overarching goal of this session is really to look at novel ways of addressing health inequities and health disparities by addressing barriers or limits to HIV testing and disclosure. And of course, we also want to find some synergies between the work that we're doing here in San Francisco and other areas in the Bay, and ultimately to brainstorm on some innovative strategies. So I'll pass it on to Eddy.
Hi, I'm Eddy Machtinger. I direct the Women's HIV program at UCSF. I feel isolated sometimes, so the structure for today, we are going to briefly set the stage. Malcolm is going to talk a little bit about testing. I'm going to talk a little bit about disclosure. And then there's going to be a rapid-fire series of 5 oral presentations. After each of the oral presentations, we're going to ask the oral presenter to go sit down next to your name tag on the panel. At the end of the 5 oral presentations, there's going to be ample time for discussion. Initially, we're going to invite questions from the audience to the panel or to the individual panelists about their studies, and then we're going to open it up both to the panel and the audience to discuss the issues more broadly. So I really hope you participate, and there were some questions about disclosure early on that I think can get amply addressed in this session. So first, Malcolm is going to talk about testing.
Thanks. Okay, so first thing is I too will apologize. Because I think Veronica, I must have pissed her off because she has me doing this session, and I said I have no expertise in HIV testing, but yet I'm supposed to frame it for us. But it was a good exercise to do some research or read about the topic. And I sent her an email too. No, it's fine. It was nice to review the topic because you're then asked to do it in a very short period of time, and I hope this helps highlight some of the things that jumped out at me. So of course we know that about 21% of the HIV population in the United States doesn't know their status. At the same time, we know that testing promotes early detection and could reduce morbidity and mortality, prolong survival, prevent ultimately further transmission as well. Yet in 2009, about 1/3 of the people who tested were still testing late. And you've heard already from our earlier speakers about some of the risk factors for late testing, older age, and immigrants and Latinos, particularly in California. And in the past, blacks had a higher rate of late presentation. Not so much now, possibly due to some successes. And we should talk about successes today as well as challenges from CDC efforts and others. But in certain subpopulations like women, it may still be a factor. I was struck by the fact that despite the successes of testing, and most people who are at highest risk seem to test more often, and indeed blacks generally test relatively frequently, high-risk blacks that is, and high-risk Latinos, but some data from the Kaiser Foundation suggests that there are some worrisome signs. So when you look at their telephone survey, about 2,300 patients or so, they've done about, 8 cycles since 1995. They basically do phone surveys, they overweight for blacks and Latinos, and then they weight the responses according to representation in the general population, and you get some results like this. And fewer individuals in general over the years say that HIV is a more urgent problem in our communities compared to their previous survey in 2006, or one of their surveys in 2006. Overall, it was down from 23% to 12% in all adults. And for blacks, it's down from 49% to 35%. So the good news, blacks have a higher level of awareness. The bad news, despite the fact blacks still make up 50% or so of the cases, new infections, and death, the trend is in the wrong direction on a national level. Same thing when you look at who have heard about HIV within the previous year. That has been down. Some good news, so nationally the CDC has told us that the one group for which HIV incidence really seems to have increased is in young black MSM. So in young individuals, there seems to be some increased awareness or concern about HIV. And when you look at this in young blacks, it's actually up to 51%. However, in the overall black population, particularly in older populations, it is less. So that is interesting. Despite these encouraging points, the last piece, only 54% of the people less than 65 have been tested, despite the CDC's guidelines and recommendations for HIV testing in all those 13 to 64, and only 21 in the previous year. In blacks, it was 43 in the previous 12 months, and 34 greater than that time, and almost a quarter of them reported never being tested. Again, when compared to the overall numbers, this is higher, but when you look at what's going on in the black community, this is discouraging. And ultimately, providers have a role to play. You see here, well, technically challenged. You see here a couple of factors, that 61% of those not tested felt they were not at risk. And if you look at other groups like the Young Men's Survey, when you ask why they were not testing, one was they didn't think they were at risk. The other is that they fear the outcome, particularly HIV stigma. But I think it's important to note that several reported doctors never actually recommended that they get tested. And so we have, for those of us who are physicians in the room and providers in the room, we have a role to play in educating our patients. And many of them do not know where to go. So all of us, regardless of our jobs or positions, have a role to play in educating people of where they can go potentially. This was an interesting study that was published in 2012, and basically it looked at some of the behavioral, some of the testing patterns for high-risk individuals and looked at sort of the locations for testing. The short version is that African Americans, Latinos, and other non-whites were less likely than whites to test in a doctor's office, were more likely to test in hospital, in particular ERs, and clinic settings. And a significant number of them, and those who were not married, were likely to test in alternative settings, jails, testing sites, etc., which underscores the importance, I think, as we listen to our presentations and talk about innovations, of looking for non-office opportunities and interventions as well. But there have been some highlights over the years as far as HIV testing goes. I'm fixated with this speaker. And basically, I highlighted in red some of the more recent successes, including the CDC changes in the CDC recommendation in 2006. The CDC also launched an initiative to address some health disparities through increased testing, in particularly vulnerable populations with an emphasis on African Americans and blacks. And as some will say, that some of the successes from that testing effort is why we're seeing less late testing in black communities, but I'll leave that to others to comment on. More recently, and of course these numbers are not surprising, and for the sake of time I'm not going to go into them, but more recently this year the FDA panel has approved or recommended that the FDA approve in-home rapid testing. And that raises a whole set of new issues in terms of access to testing, strategies to make sure people have access to that, how will they deal with positive responses and link to care. And there are folks in this audience such as Susan Buchbinder, everybody knows her well, who was put together with some collaborators, Margarita, Damon, myself, and others, to sort of look at home testing in high-risk populations such as young black MSM and link them to care. So with that, I'll pass the torch to Eddy. Thank you. Sure.
Hi. As a clinician working with HIV-positive individuals, I'm constantly struck by the insidious impact of stigma and non-disclosure on the patients I take care of and their health and well-being. I believe that the isolation caused by stigma and non-disclosure explains much of the depression, the medication non-adherence, the substance abuse, the problems with intimacy and domestic violence that we see too commonly in our programs. And I've been humbled by how hard it is to overcome these obstacles. More recently, though, I've been excited by seeing that with the right intervention, that it is actually possible to help our patients disclose their HIV status and in the process become personally empowered in every aspect of their life and health. A variety of studies have shown, so this is borne out by the literature, so a variety of studies have been done on disclosure, and some of them have conflicting results, but for the most part, the studies demonstrate that there are individual impacts of disclosure, emotionally and physiologically, and then social impacts of disclosure more broadly on couples, on communities, and on the public health. So for the most part, the studies of disclosure show that it reduces stress, anxiety, depression, and it improves self-esteem and active coping. The studies demonstrate that disclosing your HIV status leads to improved antiretroviral adherence, more use of HIV services, retention and care, and some studies suggest an improvement in immune function. And then more broadly, increased intimacy, increased social support, more safe sex, and reduced stigma personally and in a community. The same studies also do demonstrate potentially negative impacts of disclosure, and these are mentioned in red at the bottom of the sections. So some studies have shown increased stigma, perceived stigma by the individual, and psychological distress. And unfortunately, others have shown violence as a consequence of disclosure, rejection, isolation, discrimination, and in some settings, more unsafe sex. So, you know, whether disclosure goes well or not depends on a variety of contextual factors which have also been explored in the literature, and these are broken down this way. So if you look at whether a disclosure event is going to go well, you can look at the individual person's goals for the disclosure. For instance, did they want to disclose? Was this an intentional disclosure? Their own personal characteristics. Has this been a woman who has experienced violence throughout her entire life? That predisposes to violence upon disclosure. Then the characteristics of the person that you're actually disclosing to. Are they supportive or unsupportive? Some studies suggest that disclosing to mothers lead to more successful outcomes than disclosing to fathers. And then more about the characteristics of the disclosure event, what the emotional content is of the actual disclosure. And then the actual and perceived social support. And this is so important because how well the disclosure event goes predicts this feedback loop for either more disclosure and more liberation and more empowerment or more isolation. And then, so to me, the lesson is that helping our patients disclose their HIV status can be a deeply empowering and healing intervention, but that for it to be successful, it needs to be done with in understanding skills and resources to be able to address many of these aspects of disclosure that are not commonly addressed in the setting of a medical clinic. With that said, we're going to segue right into the presentations. Malcolm, I think we're going to walk over here and then announce each presenter. And what's going to happen is we're going to announce your name and the title of your presentation, come up and give your talk, and then you'll sit down right afterwards on the panel in preparation for the discussion afterwards.
So our first speaker today is Wendy Leyden, who will speak to us on mortality rates by race, ethnicity, gender, and HIV risk group.
6 inches from the mic. Okay, let's get it set up. Good morning. My name is Wendy Leyden. I'm from Kaiser Permanente's Division of Research in Oakland. On behalf of my co-authors that were supposed to be listed here, I'll be presenting. What? I don't see them. I'll be presenting the results of our study that we did among HIV-positive Kaiser members, where we compared the mortality rates by race, gender, and HIV risk group. Kaiser, as you probably know, is a large integrated healthcare delivery system that provides healthcare services to over 3 million members in Northern California. Our membership is diverse and is fairly representative of the insured California population in terms of race, ethnicity, and socioeconomic status, although not as representative of the extremes of the income spectrum. Our membership size, along with our extensive and comprehensive clinical and administrative electronic data systems, as well as our long-standing HIV registry, really provide researchers with an ideal setting in which to study different aspects of HIV disease on a large scale and with long-term follow-up. Because all Kaiser members, by definition, have comprehensive medical insurance coverage, we're also in a unique position to explore potential racial ethnic disparities in our HIV population without the confounding factor of unequal access to care. So briefly, in our study, we followed 10,000 HIV-positive patients enrolled in Kaiser between 1996 and 2009. We followed them from their entry into care until one of three things happened. They left the health plan, they died, or they reached the end of the study period of 2009. The outcome in which we were interested in was death, which we measured in two ways. First, just by crude mortality rate, the number of deaths divided by the person years followed, as well as by rate ratios, where we compared the mortality rate of different groups to a referent group in a statistical model where we could control for other factors, such as age and calendar period. The table up here shows the demographic characteristics of our population, which is unsurprisingly predominantly male, 90%, mostly white, 62%, 18% African American, 15% Hispanic, 5% Asian. And with African Americans being overrepresented and Asians underrepresented compared with the general Kaiser membership population, which is 7% African American and 17% Asian. The most common HIV exposure risk group in our sample are men who have sex with men at 74%, with some noted differences across the racial ethnic groups in the distribution of that and other HIV risk groups. This table shows our main results. First, we did not observe differences in mortality rates by race ethnicity. The crude rates were similar across groups, all approximately above 2 per 100 person years, although Hispanic patients showed a slightly lower rate. Results from the models that controlled for age, race, HIV risk group, and calendar period also show no differences in the risk of death by race ethnicity. Whites are the referent group here, and the rate ratios in the column of all years and also stratified by years, calendar era, show that the relationship held when we stratified by data over calendar period. Basically no difference compared to whites in the risk of death. Second, we did observe differences in mortality rates by HIV risk group, with the male injection drug users and the male non-injection drug users, non-MSM members, showing both a higher crude mortality rate of 2.9 and 3.1, as well as an increased rate ratio in the statistical models of 1.5 and 1.5. This increased risk, however, was more apparent in the earlier time period, 96 through 99, and was no longer statistically significant in the most recent period of 05 through 09. These two graphs show the change in crude mortality rates over time among the 4 race groups on the left and among the 4 HIV risk groups on the right. The point of these graphs is to show both a decline in mortality rates over time among all groups, no matter how you slice it, but it's also to demonstrate how the differences among the HIV risk groups diminished over time, i.e. that the increased risk seen in the earlier era among the IDUs and heterosexual other males has almost disappeared or gotten closer to the other groups in the later time period. In conclusion, to summarize, we did not observe differences in mortality rates by race ethnicity, but we did observe an increased risk among male injection drug users and male non-injection drug user, non-MSM, although this risk was no longer statistically significant in the most recent calendar period. Thank you.
So remember, we're going to have time for questions directly to the authors after all of the presentations. Thank you very much. The next presentation is by Larry McGlynn from Stanford University. The title of his talk is Risk Factors for HIV and Acceptability of HIV Testing at Community-Based Substance Abuse Treatment Centers in San Jose, California. Welcome.
Thank you. Let's see. Okay, great. Wow, it's tough to follow a study where they have 10,000 for their N. I never thought I was a size queen, but that's very impressive. So maybe I am. So background, as we all know, and thank goodness for Grant Colfax and all of his studies, meth use poses a significant risk for HIV infection. Our clinic down in, at Stanford and San Jose, we're seeing a lot of this. So we formed in 2004 the Stanford Santa Clara County Meth Task Force, and that was our focus, was really to reduce the meth use with the sort of the idea of ultimately reducing the transmission of HIV. Those who use meth, though, I've come to find out, studies really have been a challenging group to reach through various forums that we've been putting on, reaching out to the communities, etc. The SLEs, the sober living environments of San Jose, there's about 36 of them. They're seeing a lot of people still who are coming in for treatment, either voluntary or mandated, for methamphetamine addiction. This is our website, Stop Don't Start. This is one of the ways that we reach out to the community. People log on, they can get information about where they can get tested and treatment. So the objectives of this study, Stanford started working with our task force. What we wanted to do is we wanted to understand the risk factors for HIV. In this case, we're learning a lot about men who have sex with men, but we wanted to know more about the women and also the Latino men who make up a significant number of the patients at our clinics, and find out what's going on with these people in Santa Clara County. We wanted also to determine the acceptability of HIV testing in these groups. So the methods, what we did is we surveyed clients at two places, Mariposa Lodge, which is a women's SLE, and Vida Nueva, which is an SLE for Hispanic men. So we surveyed them on their knowledge and attitudes about HIV, history of previous HIV testing. We presented to them an educational session presented by myself, I'm a bilingual psychiatrist, and then a community educator, someone who was very open, willing to talk about sex and his experiences with methamphetamine. Very well received. We had a lot of fun doing it. We had two different talks. So in the fall, we gave a presentation to each of these SLEs. We focused it on meth and sex, not on HIV. But if they had questions about HIV, they could ask it. So that way we could see how interested are they about HIV. Then in the winter, we changed the talk and we made it about HIV and meth. And then, of course, they could ask questions about anything afterwards. Subjects were given $15 grocery store gift card, and we gave each a token, a numbered token, so that we could identify, not by name, it was totally anonymous, but if they had been to our program and what the demographics were of the subjects. This is Mariposa Lodge. It sits up in the hills above Highway 101 down in the south part of San Jose. Lovely cabin, rustic, really, really nice. And this is Villanueva, which is in the east side of San Jose. So the results, both women and Hispanic men who use meth, as we're finding out, have high-risk sexual behavior. Nothing really surprising there. Pre- and post-test results showed HIV knowledge increased following the educational programs, so they learned about HIV, the risk factors, etc. But the part that was really kind of a bummer, out of the 80 people that we were able to corral into our programs, only one person that we know of ultimately went and had an HIV test done at a designated site. Doesn't mean that some of them didn't go elsewhere, but when we asked them to go to this one site, we only got one person. And if you look at our poster in the back, we talk a little bit more about who this person was. So the conclusion, women and Latino men who are residents of the SLEs in Santa Clara County and being treated for meth are at high risk for HIV infection. What we found is they learn, these educational programs we give them, they do learn from them, and they really are effective in that way, but ultimately getting them tested still seems to be the challenge. Anecdotally, a lot of the people there said they were disappointed that we didn't have the mobile van there to test them or portable testing equipment. So as we move forward with our with our intervention into this community, we hope we'll be able to step it up and start getting the van involved. So barriers still seem to be present, even though people learn to ultimately get the testing done is a challenge. So I think that's it.
Thank you very much. Next, we have Sandi McCoy, who will be speaking on enhancing HIV testing and linkage to care with peer recruitment, financial incentives, and more.
Thank you. Good morning, everyone. I'm Sandi McCoy. I'm an epidemiologist at UC Berkeley, and I'm presenting the results from our study, the Oakland Connect study, on behalf of all of our co-authors. And I'd just like to present our great team who coordinated all of this work: CalPEP, Get Screened Oakland, Casa Segura, or the HIV Education and Prevention Project of Alameda County, Volunteers of America Bay Area, and the AIDS Healthcare Foundation, and specifically the Out of the Closet store in Oakland. So as we've all heard this morning, the timely detection of HIV infection and linkage to care and treatment are associated with increased survival and reduced onward transmission. But we know that 1 in 5 people living with HIV infection in the United States do not know their status. And therefore, we need new and non-stigmatizing strategies to increase demand for HIV testing, especially among African American adults who are disproportionately affected by the epidemic. Many of you have probably seen this graph before. These are Alameda County AIDS case rates. You can see that there's this really staggering racial disparity in AIDS case rates, especially among the last year. Case rates among African Americans were roughly 4 times that among whites. So this is the underlying motivation for our study. So the objectives of Oakland Connect are to compare the effectiveness of respondent-driven sampling with 2 different incentive schemes for increasing the demand for HIV testing among 30 to 60-year-old African American adults residing in Oakland, California. And for those of you who aren't familiar with respondent-driven sampling, this is a peer recruitment technique where we invite people to join the study and then to recruit other people in their social network to join the study. And this process repeats itself in multiple recruitment waves so that you end up with long chains of social networks. We've also focused on 30 to 60-year-old adults in Oakland because this is the population where we see a lot of late diagnoses. And so we wanted to increase the demand for HIV testing in this group. The second objective of our study was to determine if the HIV status of recruiters is associated with differences in the total number of recruits and also with the number of high-risk recruits that they bring into the study. So as I mentioned, we used the respondent-driven sampling platform for this study, but we had 2 variations on the standard RDS approach. The first is that we evaluated 2 different incentive schemes. So acknowledging that you can use incentives to motivate people to adopt healthy behaviors, we randomized all of our participants into 2 different study arms. In one study arm, participants received a flat fee for recruiting others into the study. This is the standard respondent-driven sampling approach. We added a twist to this, though, to see if we could improve the efficiency of HIV testing. In the second study arm, participants were given a flat fee for recruiting others, but they were given bonuses for bringing in people who we were particularly interested in enrolling in. Never been tested for HIV before, or maybe who had never been tested in the last year. And so you can see our poster, which is number 4, to learn all about all of the bonus schemes that we offered to people. The second variation we added onto our study is that we initiated our networks with both HIV-positive and HIV-negative seeds. So seeds are the initial people that you recruit into a study to begin your respondent-driven sampling networks. So we enrolled both HIV-negative and HIV-positive people into the study to start these networks. So in the example shown on the slide, this is an example network that came from our study. We started with a person who already knew their serostatus and it asked them to invite other people into the study. And then we compared the networks that were generated from these 2 approaches. So overall, we started with 48 seeds. 10 of these were people who were already aware of their HIV-positive serostatus. And over the course of about a year, they recruited 243 other people who met the eligibility criteria, which were African American adults living in Oakland between 30 and 60 years of age. So I'll invite you to our poster to see all of the details of the study, but here are the bottom lines. We found that incentives were critical for recruitment. In fact, that probably drove all of the main reasons that people joined the study. But we didn't find any difference in the number of total or high-risk recruits between the 2 incentive schemes. So in the end, we weren't able to improve the efficiency of testing using these 2 schemes, but we know that overall the incentives were crucial. However, we found that networks that were initiated by people living with HIV infection had more high-risk recruits than networks initiated by HIV-negative seeds. This was a statistically significant result, and this tells us what many of us know, which is that people living with HIV infection are our partners in prevention efforts. And finally, 9 of our recruits tested HIV positive. This was 3.7%. However, we found that 7 of them were previously reported to the Alameda County Public Health Department. 6 of these 7 individuals had no evidence of care in the last 6 months. So this was a surprising finding. Our study was designed to identify people who were unaware of their serostatus. We didn't know we were actually going to re-identify many people who were already aware of their serostatus. So this leads us to our next question, which is maybe RDS is a good mechanism to help reconnect people living with HIV into care. And it also underscores the importance of linkage to care after diagnosis. So with that, I'll just thank all of the people who participated in the study, as well as the California HIV/AIDS Research Program, which funded it. Thank you very much.
Next, we'll have Yamini Bhatnagar, who will be presenting social networks, HIV testing, and youth clinic in Oakland. Is that what
It's Yamini Bhatnagar, but thank you. Good morning. In the same vein as Sandi's presentation, I will be talking about social network HIV testing at Downtown Youth Clinic in Oakland. To begin with, just the basis of our work at the Downtown Youth Clinic and the East Bay AIDS Center is really to intervene in this epidemic, especially to highlight the fact that young people are getting infected with HIV at higher rates. We talked a little bit earlier about the rates across the nation, the rates in the Bay Area and in California, and a little bit about Alameda County. But let's look specifically at Oakland. The HIV prevalence in Oakland looks a little bit like this. It's almost twice the nation. This is based on some statistics from the Alameda County Office of AIDS in 2008 and some CDC statistics from 2006. The prevalence is 850 of 100,000 versus 448 in the nation. MSMs counted for 58% versus 48% nationally, and 59% were African American versus 46% nationally. A little bit about the Downtown Youth Clinic, who we are. We are the youth track, or the youth program, at the East Bay AIDS Center in Oakland. We have dubbed ourselves a clinic without walls. A lot of the work that we do is actually not within our 4 walls. We go out into the community for HIV testing. We go out into the community for peer advocacy. We go out in the community to find people, to link them to care, to meet them at coffee shops, in their homes, at their schools. We go out in the community to aid in the retention in care, and also in community building activities. This Friday, we're taking a bunch of our youth to Great America for Pride Day, and that's all part of our work in maintaining these young people in care once they test positive. We currently have over 100 HIV-positive youth, 13 to 24, in care. 65% of those are African American, greater than 65% are African American, greater than 70% are MSM, identify as MSM. A little bit about our model. It's all about finding HIV-positive youth, then linking them to care, then maintaining or retaining them in care, and moving forward to preventing new infections. And this is what we'll be talking about now, finding HIV-positive youth, and the program that we piloted to do so. Our social network testing program was alive and kicking from January 2010 to June 2010. We fundraised specifically to be able to provide these incentives I'll talk about. We hired or recruited our HIV-positive youth as index patients to then go out and bring us their friends, their sexual networks, their social networks, bring them in for HIV testing. We paid our index patients $10 cash incentives per referral and $20 cash incentives per youth that was paid to every referral that actually came in for testing. Counseling was provided to all of the youth referred for HIV testing. Risk reduction plans were made, and follow-up plans for testing were also made with these youth. some of our results, we found 14% to be newly diagnosed. We tested 78, nothing like the 10,000 that were talked about earlier. A very small group here. 78 were tested, 65 tested negative, 13 tested positive, of which, like Sandi said, we found that 2 were actually previously diagnosed, and we relinked them into care. 11 of those that were newly diagnosed, as it goes in this work, 7 were linked to care and 6 retained in care at 6 months after this project ended. 4 were not successfully linked, and 1 was not successfully retained. A little bit to show what these networks looked like, actually. And it was so different with all of our index patients, all 11 of our index patients. 1 brought in 25, of which only 2 tested positive only. 1 brought in 17, of which 7 tested positive. A lot of people who brought in simply just their partners, all, as you can see, brought in 1 person, and that person ended up testing positive. So this is kind of what it ended up looking like. A little visual to just show how much this is really high-yield testing. This was created by Dr. Francis, who's sitting up here, and Dr. Sophie Wong at the AETC in the East Bay. Just to sort of visualize, emergency departments, 1 tested positive out of 298. This was based on Highland Hospital. At MSM venues like Bench and Bar, for example, in Oakland, or Steamworks, 1 out of 30 test positive. Social networks among adults, we found that 1 out of 17 test positive, and this is also from the East Bay AIDS Center. And lastly, youth social networks, where we found 1 in 7 have tested positive. A little bit about the stigma that we find is really prevalent among what happens with these young people. We found in many cases, in one case, a young trans woman didn't want us to disclose her status or her preliminary test result to her, even because she didn't want to feel really upset when she went back out into the waiting room and found her friends there. Confirmatory blood work, we found that 4 people actually did not return for that. Linkage to care, there's always stigma associated with it. We found that one of the youth, it actually took over 6 months of texting. People, that's why we text. Do things like take them to Great America, etc. Lastly, in the vein of reducing disparities, the National HIV/AIDS Strategy, and what we've been talking about all morning, this is a way that we've been able to reach a marginalized community. Young people of color, putting actual cash, actual money into their pockets has really been a way in which we've got people in, not only to actually test, but we've gotten young people, index patients who were out of care, to reestablish in care simply because this was a way for them to get money as well as sort of reconnect with us, and then now some are actually back in care. And lastly, just some acknowledgments of my team, and thank you very much.
Next we have 3 abstracts collapsed into one presentation by Star Hillard. These abstracts are by Star Hillard, Sonia Ray, and Kristen Capito. The presenter is Star Hillard, and the title is A Theatrical Performance Group Intervention to Empower HIV-Positive Women to Publicly Disclose Their HIV Status, an Analysis of the Impact and Process.
Hi, so my name is Star Hilliard, and I'm a student in the Global Health Sciences Master's Program, and I also work with Eddy Machtinger over at the Women's HIV Program. And our authors today are listed alphabetically, and I'm going to collapse 3 abstracts, first authored by myself, Sonia Ray, and Kristen Capito, into one oral presentation. Stigma, isolation, and non-disclosure contribute to poor health outcomes among HIV-positive women, despite access to quality health care. Novel approaches to caring for women living with HIV include expressive therapy and disclosure. Expressive therapy is associated with increased immune function, self-efficacy, and coping, and it's associated with decreased risk behaviors and perceptions of stigma. Disclosure is associated with increased social support and HIV service use and increased medication adherence. Disclosure is also associated with decreased depressive symptoms. In an effort to overcome stigma, isolation, and non-disclosure, the Women's HIV program partnered with Rodessa Jones and the San Francisco-based arts organization Cultural Odyssey to incorporate HIV-positive women into a theatrical performance group intervention. For over a year, participants met weekly as a group where they translated HIV-related personal experiences into performance vignettes. The intervention culminated in a series of 8 theatrical performances seen by over 1,000 people in March 2010. So a lot of the participants and the audience members described this experience as transformative. And so we really wanted to take a closer look at that and see what they meant by transformative. So after the performance, we conducted a qualitative analysis in which we interviewed all 8 HIV-positive participants and 5 of 7 HIV-negative participants. And we used thematic analysis to determine the process and impact of the intervention. So before I launch into results, I just want to play you a short clip from the performance to give you a better feel of what the performance felt like.
You're all tripped out! I'm so sorry. I was naive and thinking nothing would happen to you. I know you were trying your best. You just didn't have the teamwork to help you. You're broken right now, but you can be fixed. You still work. You're just handicapped. And I can help you. I now have the equipment to mend you now. We have the #1 doctor, Dr. Eddy. Our family and our friends support you. But all of this will make you better and stronger. And together, with our brain, our heart, and our soul, blood, you'll be well again. Blood, look. Look how you're flowing now. Your colors come back. T-cells are going up. Viral loads coming down. Blood, look. You're doing it. We're doing it. Hell, we did it.
So of the 15 total participants, 8 were HIV positive and 7 were HIV negative. 46% were African American, and ages ranged between 23 and 65 years of age. All participants had earned at minimum a high school diploma. And for the HIV positive participants, the women had been living with HIV for between 1 and 24 years. All HIV positive participants disclosed their status during the performance. So we examined what the participants said about the process of the the process of the intervention, and we determined that there were 5 core elements. First, the formation of community, in which participants described forming honest and trusting relationships. Writing, in which participants received prompts, wrote stories at home, and then read them aloud to the group when they met weekly. Movement, in which participants partook in dancing, stretching, and expressive exercises. Personal transformation, in which participants described gaining self-esteem, self-identity, a voice, and a sense of purpose. Performance, in which the written vignettes were translated into a public performance. Additionally, participants described the crucial role of an active the crucial role of a skilled and present leader, especially her ability to herself show up and to share her life with them. We further analyzed the core element of writing because it was such an important part of the overall process. So during the theatrical workshops, participants were prompted to write on a variety of topics, including living with HIV, identity, and relationships. One example of a prompt would be, what is the difference between sex and intimacy? So our analysis of participant responses determined that there are 3 core elements of the writing process. First, confronting the challenge of writing, in which participants overcame long-standing insecurities about writing. Second, private personal exploration. Writing prompts challenged participants to privately address past traumatic experiences. And third, reading the writing to the group, in which participants selected written vignettes to read aloud to the group. So 5 themes describing the impact on HIV-positive participants emerged from the participant interviews. Formation of community, in which the women described really creating a sisterhood, and that's a word from the interviews. Second, decreasing isolation, in which relationships among participants contextualized health and highlighted shared experiences. Normalizing HIV, in which participants learned that being HIV positive is okay. Developing a sense of purpose, in which participants gained a desire to teach others about HIV and combat stigma. And lastly, personal transformation, in which participants positively redefined their self-identities and increased their self-esteem. An example of a personal transformation quote is, as cliche as it sounds, it also just emphasized that you're Sarah, you just happen to be positive. You're not positive and your name is Sarah. The process of this intervention created an environment for HIV-positive women to effectively address and overcome the HIV-related stigma, isolation, and non-disclosure. Our findings show that an HIV-focused theatrical performance group can profoundly impact the lives of marginalized HIV-positive women. Given the disproportionate burden of HIV morbidity and mortality carried by women, this intervention represents a unique way to confront and diminish the challenges of living with HIV and disparities in health outcomes. Thank you.
So thank you for a group of very impressive and interesting presentations. Those were great. I want to introduce a special guest to the panel, and then we have 20 minutes for open discussion, ideally led by your questions, and we have some of our own. I'd like to introduce Sonia Rastogi. Sonia was a participant in the Medea Theatrical Disclosure Project, and now she's the advocacy coordinator for World and for the U.S. Positive Women's Network. Sonia, thank you so much for joining us. So the first part is supposed to be questions from the audience to the individual authors, but frankly, I'd just like to open it up to questions from the audience and see where people are and where that goes. And maybe I'll start. So I just had a question for Larry about his presentation regarding an educational session, and I wonder what your thoughts are about knowledge as an intervention versus emotional engagement and contact as an intervention, and wonder if you think that the educational sessions got deep enough in terms of trauma or other life experiences that informed why these people were using substance use to begin with.
That's a wonderful question because it sort of leads into the other poster we have, which is on expressive writing, which Peter Marcus will present later. And in that one, we really found getting in depth, we're getting a lot more meat sort of substance to it. The educational programs themselves, though, were just so engaging, and the women having two guys coming into the house, and they were so frank with their questions, very in-depth sexual questions about everything, I mean, that you can imagine, but did it get to the emotional part as you're asking, you know, the things that may perhaps be the barrier, such as shame and stigma and people's ultimate feelings about themselves and others? And I don't think so. I think it was the educational part that was really nice to see them learning, but ultimately, would they then go on and get tested? As our study showed, no, they didn't. And so I don't know if that answers your question, but it would, in that sort of context of having a room of 35 women or about 20 bilingual Hispanic men who were also in a way challenging to reach. I speak Spanish, and so I was able to sort of go back and forth with them, and they had, I think they built a sense of trust because the guy who was with me was able to really open up and talk about being a heterosexual who, when he's high, will have sex with other men, and that got them to asking their questions. So anyway, long story short, sorry, is yes, I think we need to go deeper, and that may be one of the areas.
I just wanted to follow up, you know, you alluded to the fact that you didn't have on-site testing and that may be a barrier. Is there anyone here from BCA, Black Coalition on AIDS? Because I know Melinda was doing a community-based intervention for women where they had a sort of Oprah-type session on the stage, and people came up and talked, and then they had testing in the back. Anyone knows Melinda Evers? Okay.
So I think we have a question at microphone 1.
Good morning. Thank you, everyone, for your really excellent and interesting presentations. My question's for Dr. Leyden, and I'm wondering if you had any opportunity or you were able to look at socioeconomic status among the different groups you were looking at in terms of mortality. I know that everyone had Kaiser, but I would imagine someone who had maybe Medicare along with Kaiser might be different than someone who had more comprehensive coverage.
Thank you. First of all, I'm not a doctor, not that there's anything wrong with being a doctor, but we did actually have a measure of socioeconomic status, but it was only census-based, so it wasn't direct knowledge of a person's household income or the neighborhood that they live in. We just tied it to the census tract that they live in. So I did look at that in the models, and there was no effect on the rates that we saw by race or by HIV risk group when I included income in the models, and income itself didn't track with the different mortality rates. I think that's one of the limitations of the data that we can look at Kaiser, and it would be great to have personal, individual-based income and socioeconomic status indicators to look at, because, that's driving a lot of it.
Thank you. Esteemed colleague at microphone 2.
I actually had the same question, but I wondered, Wendy, if you could just say more about what your thoughts were about the data, because you presented the data, but I would love to hear sort of what that means, because even it goes against national data, right? If we look at it just nationally, but you're giving us a very interesting context of looking within a health insurance model, and just wondered if you could say more about that.
Well, I guess maybe you're asking me if I found the findings surprising, because it does kind of go against a lot of data that looks at, that finds differences by race. And in the mortality rates, we did not find those differences. And I think it is probably because the Kaiser population is a bit more homogeneous in socioeconomic status indicators. And it's an employed population. And like I said, we don't really have great income information at the individual level to really, or even, further information, like what neighborhood they live in, to really look at that. There is a difference just looking at census data among the races, I mean, the African Americans do in general have about a $10,000 lower average household income compared to whites and Asians, and Hispanics are kind of in the middle. But I don't know. I hope that answers your questions. I guess it's surprising, but not that surprising. I wish we had better information to get at what is going on.
Thank you. Susan, microphone one.
Yeah, I'm interested in this issue of re-diagnosis of HIV. So people who have received a positive diagnosis before or have been reported as positive before, but perhaps weren't aware that they were positive. So I was interested in both the Oakland Connect and the DYC clinic experiences, and if you could speak to that, if you know anything more about the circumstances under which people fell out of care.
So we don't know for Oakland Connect anything about the people who had already been reported, because in terms of informed consent, we don't have their permission to recontact them. So we actually, what I would love to do is go back and interview these individuals and find out what happened to them. So we can't, but that's potentially something we could discuss with our partners to find out what had happened to them. I initially thought when this happened in our study that people were entering the study because they wanted to get the incentive. And I think the incentives were really critical in this essence, that they came in, they could confirm their HIV diagnosis and get a $10 incentive. But if it was all about the incentive, we might have expected to see them being really efficient recruiters. And in fact, none of the people who were previously known positives recruited anyone. So it's clear to me that it wasn't entirely driven about economics, because they could have made actually quite a bit of money had they recruited anyone, and they didn't. They just came in, got the $10 incentive for testing, and left. So I think it might be some of this phenomenon where people test at different places a few times to confirm that maybe they are positive, or they think if they've been out of care for some time that they'd like to make sure they're still infected.
Who is next?
Oh, there was
Go ahead.
No, I definitely agree with everything that Sandi said. I also think another thing that happens is, especially with youth, I don't know that it happens with adults, but youth will come in to get tested, even though they've tested positive in the past, just to be part of that negative peer group, and just to sort of represent with that peer group, to not disclose their status to anyone else. That's another thing that I've seen that's happened. And one last thing is that I've talked to people who have sort of retested, and anecdotally, it's been a way for people to get into care, which they didn't know any other way how to do so.
Hi, I'm Susan Kegelis from UCSF. I'm co-director of CAPS. Wendy, you get yet another question. You're very popular today. I also was very interested in your data, because a lot of times when people talk about disparities, they automatically assume that it's an access problem. So having a population that all have access is great. What I want to know is, did you look at MSM issues, ethnic racial differences among MSM in particular? You didn't report it here, and I'm wondering if you found differences. So that's one thing. The second thing is, I just want to put in a general comment, not necessarily to this group, but at large. Something I am very concerned about with respect to disparities is that it seems like the national plan may not directly be trying to do it, but indirectly is leading to a lot of community-based organizations that specifically reach people of color going under. And it's something I'm very, very concerned, because I don't believe that health departments are going to be the ones that know how to reach the populations at risk. So it's an editorial comment, but I think it really impacts disparities issues. Thank you.
I'll try to remember your question. Right. Well, we didn't look at mortality rates specifically by MSM within each race, if that's what you're asking.
Yeah, you weren't able to look at that.
Well, I'm not sure if we weren't able to or we just didn't yet. But that's a good question for further thought.
That would be a very interesting thing to pursue.
Yeah.
Microphone one.
Hi, my name is Carol Lawson-Rose.
No.
Come over to
Hi, my name's Carol Dawson-Rose, and I'm also at UCSF. I'm from the School of Nursing.
And I have sort of a different question to ask you. I mean, it's such a range of different presentations, but, and I've been working with Eddy and the group on this Rodessa analysis of this data. And if we're looking at the framework of social disparities, or sort of, you know, what are the upstream issues that really relate to some of the disparities in health outcomes, how can we take what we're doing with people who are HIV infected, social network, youth, you know, the Rodessa Project, World, and transfer that to the people who have the same situation, stigma, violence, you know, all of these things, to keep them uninfected? I think that's one area we're really not doing, we could do more in, and I'm wondering if any of our panelists have any ideas about that, because I think we do some amazing things with people once they're infected. How can we do that with the same groups of people before they're infected? That's my comment.
I might ask Sonia. Well, maybe Sonia can begin addressing that from her perspective. I'd like, Carol, I want that to inform some of our remaining questions, but I'm going to ask Sonia to just make some overall comments about her take and her experience of what was presented today from a unique perspective, and hopefully we can get back to how we can have an impact of what we've learned here on HIV negative at-risk populations.
Thanks, Eddy. Yeah, I hope I can get back to, in a circular way, maybe come full circle to that point. I had a couple of thoughts listening to the different presentations, and also just the topic of testing and disclosure, and to start with the role of the Medea Project and its impact on me personally. So I'm a positive woman, and the Medea Project was the first place where I was able to discuss and heal and talk about HIV, sexuality, sexual and reproductive health, future reproductive desires, and violence in an area that was not clinical. And the reason why I stress not clinical is because for everyone, and in this context for positive people, the medical and clinical part is not the majority of what's on your mind. It's not the majority of your issues. Going to see a doctor is important, getting amazing care is important, but there's, you know, maybe 70–75% of your life that's not dealt with in a clinical setting. And so the Medea Project really helped me and a lot of other women open up and deal with a lot of deep violence and trauma in our lives. And that brings me to 2 points that I want to bring up for discussion. One is the role of violence and trauma in whether you're positive or negative, and the role of HIV criminalization. And I'll start with criminalization first, in that when we're talking about access to testing or getting tested or disclosing, HIV criminalization is very real, and there are exposure and transmission laws. They're in 36 different states and 2 territories in the US. And what they are, California has an HIV testing and disclosure law. And in each state is different, but some of the commonality is that if you're an HIV positive person, you can be criminalized for quote unquote knowingly transmitting HIV to your partner. And that knowingly piece around disclosure, I mean, we can have a whole conversation around criminalization, but that's a clear deterrent for people who want to get tested. I don't want to know my status because I don't want to be criminalized. Sentencing goes from 6 months to 25 years. People walk out of those sentences as sex offenders. In the state of Louisiana, you get a sex offender on your driver's license. In the state of Mississippi, this was recently repealed, but when people tested positive, the Mississippi Health Department had you initial saying that as a woman that you would not get pregnant and that you would not transmit. And luckily last year that was repealed, but I mean this is very, very real when you talk about testing and disclosure and the fear of getting tested or the fear of disclosing, and then linking into violence and trauma for people, whether it's trauma from an earlier part of your life, whether it's your childhood, whether it was your growing up, or whether it's violence and trauma in your current relationship, or gender-based violence in the community. And this is a place where I'd also like to defer to Eddy and UCSF, the Women's HIV program. They've done a lot of work on trauma. But that piece on being able to have an open communication about sex and having to disclose, I mean, At World last year, we lost about 8 or 9 women, and we didn't lose them because of lack of access to care, or that they weren't linked, or that they didn't have resources. We lost them because they could not disclose, or they did disclose and they were abused, and in one case murdered. And so I think when we talk about meaningfully looking at people's lives and these upstream issues, these social determinants of health, as you say, that really plays a huge role into how people engage and interact with services. So, and going back to the piece around engaging folks who are HIV negative, I don't really have a clear answer for that, but one of my thoughts, this is what we've been talking about at World, is that it's really hard to get folks who are HIV negative to plug into an HIV space. And that's, HIV might not be the first thing on their mind. So how do you kind of create this community around HIV when for positive people it's a little bit different, but for HIV negative folks it might be hard.
So we have time for about 2 more questions before lunch. Thank you, Sonia, that was great.
I'm Sally Sloan from Kaiser again, and I just wanted to respond to the earlier question about the lack of difference in outcome by race that was posed to Wendy. And I want to say I don't think it's got anything to do with socioeconomics. I chair the Northern California Kaiser Regional HIV Advisory Group, and we take care of folks that are homeless and marginally housed. And I think that it's really got to do with the fact we have a very robust division of research. We have an electronic medical record. Every Northern California Kaiser healthcare facility has a multidisciplinary team of providers, and we get a lot of feedback on how we're doing. We can send people how many of their patients that are on antiretrovirals are not undetectable, when people got their last labs done, when they were last seen, and we have case managers and pharmacists and dietitians and health educators and social workers that then go and find our patients and get them into care and help them with adherence. So I really don't think it's got a lot to do with socioeconomics. I mean, they all are insured, but it's really being able to use our data from the Division of Research to plug back into the clinical setting to improve our services. And I think that's a lot what it's got to do with.
Okay, we have 2 more individuals. Let's just take both, 3. Right here.
Hi, this question is for Dr. Machtinger. Is this it's not working again? Oh, it is working. Hi, so you were talking about disclosure and some of the outcomes of disclosure, and I'm wondering about whether or not there's some relationship between sort of the liberation and the catharsis of disclosure and education, and especially going into research and HIV research, especially because we've been talking about, you know, getting back into the community and finding innovative ways of getting back into the communities. And, you know, people who are positive, they've been there, they've done that. So I'm wondering if you've seen any relationship with that.
So I'm going to defer this question to Sonia Ray, who's a master's candidate who just did her thesis on the disclosure process model and a review of the literature. I don't know, Sonia, if you have any insight into that question or you need clarification.
Yeah, I'd like clarification, actually. So do you mean people who are higher educated experience more catharsis from disclosure, or what do you mean?
People who disclose, are they more likely, or are they more motivated to go into higher levels of education, especially into HIV research?
That's a really interesting question. I haven't seen like quantitative studies to show, but I have seen qualitative studies that do show one key impact of public disclosure is that desire to help other people. And like on an individual level, people have, you know, gotten more involved in HIV issues as they are more open about their status and start to learn more about issues affecting other people with HIV. You know, one of the parts, you know, when you disclose, and you're disclosing to other people who are affected by HIV too, you start to realize that your experiences are shared by other people. And that kind of, for some people, it helps mobilize, you know, a sort of political activism and wanting to get more involved in issues affecting HIV. But I haven't seen, I think it'd be interesting to try to quantify that, but it's definitely a possibility, yeah.
Just one anecdote is the woman sitting right next to me who participated in this project and is now the coordinator of the U.S. Positive Women's Network and for World on a national level, and is moving on to be a very important national advocate for this issue.
I'm an anecdote too, so.
Oh, excellent. Thank you.
Thanks.
I was glad to hear the presentations about the social network testing, and kind of building on the earlier presentation. I wanted to know how you see, for HIV negatives, how to get social network testing into communities like East Oakland where there isn't testing. So that's my question.
Well, I think that also brings up some ideas that were brought up in the prior question about waiting for people to be positive and then providing them with concierge level service, which certainly feels like we do sometimes with all the categorical funding that comes into HIV. I think the answer is really to go to the people and ask them questions, and also go to the people you want to reach and ask them questions, and then go to the people you want to reach and also have some design thinking. So even if you don't get the answers exactly that you're looking for, but really watch, understand, learn how people are utilizing services, and then try to design. I think a lot more is learned by sort of experimenting, and that process that Dr. Sloan described of just knowing your results. You may not even understand why something you try to do works, but I think we really need to get down and dirty and sort of measure those things, watch people use our system and figure out, like, do they like it like this? Do they like it like that? And provide options, you know, and just target that as an idea. But we need resources to do that, and right now, the way that HIV is funded really makes it very challenging, even though it's our mission at DYC to do that work, to reach negatives before they come into care. It makes it really challenging to do.
Unfortunately, we are out of time, so I'm going to pass this to Veronica. Thank you.
Thanks. That was another wonderful panel discussion. Thank you all for all of those presentations and the discussion. We need to move to lunch now because, as I said, this is a very, very packed day. What we will do is, once everybody's gotten their lunch and come back in here at about 12:20 or so, we will have a very special keynote address by Dr. Joan Reed, who is joining us from Harvard University, to talk about diversity in the workforce. And then that will be followed by the first of the theatrical presentations. So keep those questions you have, ask them to the individuals during lunch or the coffee break or this evening during the reception. Go get your lunch, come back in so we can get settled down for the special keynote presentation. Thanks. A hand to the moderators and the panel. Thank you.